This podcast is on ultrasound, instrumentation, and image acquisition. We're going to discuss how to obtain an ultrasound image, which transducer to use. We'll discuss some artifacts and really get you going to try to get those images on the screen to look nice. Bats have been using ultrasound to find their prey for thousands and thousands of years, and so have dolphins. And eventually, the military started to use it with sonar to find its prey as well. But luckily for us, in 1965, humans started using it for good, and we could see structures in the body using ultrasound. Now, initially, these machines were gigantic things, and we're looking at babies connected to an oscilloscope, but ultimately, we really perfected the use of this device, and ironically, here we are using it on a bat to find a pregnancy inside this little animal. Such a cute picture there. But the machines themselves have gotten very small. They've grown from these massive structures in the last 30 years to really much more handheld, compact devices. And this is a great way to look inside of our patients to find out what's going on at the point of care, something we call POCUS, point of care ultrasound. And really the only other way to look inside the body is to use a scalpel or to use ionizing radiation, such as this CT scan here. One CT scan of the abdomen, pelvis is equal to roughly 500 to 1,000 chest x-rays worth of radiation. So if we could avoid unnecessary use of radiation by using point-of-care ultrasound, well, then we should. The current healthcare structure in the United States is super complicated. And one of the things I think that really connects the physician and the patient is just being in the same room together and performing a physical examination on them. And I think that that's where ultrasound really comes into play, because it necessarily forces me to put probe to patient, thereby connecting me with my patient. And I can show them what's wrong with their organs right there on the screen at the bedside, at the point of care. Now, Dr. Abraham Verghese is sort of a modern-day William Osler, and he wrote something called the Stanford 25. It's the 25 things every Stanford medical student's got to be able to do with the physical examination. And we took it a little bit further at UC Irvine. We called the UCI 30, the 30 things that all UCI medical students should be able to do with ultrasound, and published it a couple years ago. And in the UCI 30, we look at the entire body, from the brain and the eye all the way down through the ankle. And this is going to be important going forward, I think, as we try to reduce healthcare costs. A couple ways to do that with scale and integration, operational improvements, but it's this clinical re-engineering, what we do at the bedside. Changing what we do at the bedside by eliminating unnecessary testing is really going to cut down on a lot of the cost of healthcare, and that's right where ultrasound fits in. So how exactly does ultrasound work? We're going to talk more about the physics now, and no better person to explain ultrasound physics than Sean Connery himself.
Re-verify our range to target. One ping only. I just... Your ping, silly. One ping only, please. I got... What the hell is this about?
Russians want us to sink her. We'll have to do that.
So one ping only. This is a classic scene from The Hunt for Red October, and it basically means, he said, re-verify our range to target. And what he means is he releases the ping, he knows how fast sound travels through water, and then he just times the time of flight. He listens for the time of flight for the ping to go from one submarine out to the other and then back again. And then the other submarine hears this ping and realizing that the whole point of the movie was that he was trying to defect and give up his position. And, well, I won't spoil it for you. But that's how ultrasound works. We know how fast sound travels through water. or in this case, human tissue, 1,540 meters per second through human tissue. And so the machine lets out a ping, waits for its release, and then it plots a dot on the screen. And depending how long the sound took to go out and come back, it plots a dot on the screen in terms of depth. And so the longer it takes to come back, the further down the screen is going to plot that dot. So as the machine is listening for the echoes to travel into and then back out of the body again, the longer it takes the echoes to come back to the machine, the further down the screen it's going to plot the dots. So the skin line is up here, the sound is going 5, 10, 15 centimeters into human tissue, so the structures down here on this side of the screen took longer to come back to the probe. That's why it plots it further down the screen. It's all about depth and time it takes to come back to the screen. And it's also about density. The denser the object, the more echo bright it is. This is the diaphragm here. It's a relatively dense muscular structure, so it's very echo bright. This anechoic structure here is a hepatic vein. Hepatic vein, that's just fluid, blood flowing in the liver, and it's not dense at all, so it's not very bright. In fact, it's quite dark. Now, the different modes on the ultrasound machine, you can see here, this is the main control panel here that controls the modes of the ultrasound. And the first mode I'm pointing out to you is straight up 1972 ultrasound, or brightness mode, B mode. We can see it there with the yellow arrow. Now, when you activate that button, you're going to get white dots on a black background. The next mode I want to tell you about is M mode, or motion mode, and we use this primarily in the heart to look at the various contractility in valves. And what we do with M mode is we can see structures, its motion over time. It's created as a graphical representation, and stuff that's squiggly moving up and down is moving. Stuff that's more horizontal is not moving. And so that's basically what this is. This is a still image showing the pathway, whatever was underneath this M mode spike here. Either it's moving or it's not, but you can make out this structure here being the septum of the heart and the parasternal long axis, this being the posterior wall. We see the septum here and then the posterior wall down here. And between those two structures, you'll see the movement of the mitral valve. Color flow Doppler, or CF, is basically the shift of Doppler frequencies of the red blood cells moving towards the probe or away from the probe. And during diastole, moving from the left atrium to the left ventricle, we see this red blush of flow here, red blush of flow going up here. And then during systole, unfortunately for this patient, when the left ventricle squeezes, there's a big blue jet that backwalls the left atrium, blue away from the probe because of this incompetent mitral valve regurgitating its flow back into the left atrium. And that's how color flow Doppler works. It is a directional type of flow looking at the Doppler shift in frequencies of the moving red blood cells. And then pulsed wave Doppler, or PW, is another type of Doppler that shows velocity. And so what you're doing is you're taking the sampling gate here, looks like a TIE fighter from Star Wars, and you're placing it over a vascular structure, and then you can actually measure how fast those moving red blood cells are. In this case, this value here corresponds to 7.6 centimeters per second during systole, and then during diastole, there's still some good forward flow here at 3 centimeters per second. So these are velocity waveforms, pulse wave Doppler, sometimes called spectral Doppler. Now, I talked to you about those dots being brighter or darker. Well, that's kind of a confusing language to use, so we're going to use a uniform language of echogenicity. Structures are hyperechoic if they're more echogenic than surrounding tissue, hypoechoic if less echogenic, and anechoic if completely devoid of echoes. So blood in its moving state, non-clotted form, liquid state, is anechoic or jet black. So is the urine, bile, structures such as that. Now, there's this whole issue of frequency when it comes to ultrasound machines, and as you increase the frequency, you definitely get better resolution, but the sound can't penetrate as far. So the idea is you want to choose the correct transducer that will give you the best possible frequency at that depth of penetration. So it's sort of like lenses on a camera. This low frequency probe here, think of that like a telephoto lens. You're looking far away into the body in this case. This very high frequency linear probe here has a high frequency bandwidth, so the frequency is beautiful, but it can only see structures up really close, sort of like a macro lens on a camera. And so then you've got this mid-range frequency transducer here, large footprint curvilinear probe, that is sort of a balance between low and high frequencies. So it can penetrate pretty good, but also gets nice, pretty images. And you can actually turn up and down the frequency within one transducer. Notice there's a range here, 2 to 5, 4 to 13, 1.7 to 4. So we can bump it up or bump it down using the controls here underneath the screen here, this primary control panel. But so, you see this area here, this is like a mid-frequency, somewhere halfway between the two frequency bandwidths. Let's say if the probe goes from, like, I don't know, 1 to 5 megahertz, this would be the 3 megahertz setting here, and the dots are pretty close together, so a pretty resolute image. When you turn up the frequency to that, say, 5 megahertz range, now the dots got a little bit tighter, a little bit closer together. The sound doesn't penetrate as well, but the image is more resolute. And as you bump it down to that lowest frequency setting, say 1 megahertz, now the dots splay away from each other, and it's, I don't want to say the word grainy, but it's a little grainier than the other images. So I'll go back to the previous resolution, high frequency mode here, like 5 megahertz. Dots are very close together, and then the other extreme down here to the lower frequency mode. So when would I use this? In patients who are really big, like 150 kilograms, let's say, then I'm going to be using that low frequency setting. In this case, I'm looking at Morrison's pouch. This happens to be the kidney right here. This is all the liver up here. Here's the diaphragm. Now, if I have a smaller person, let's say, I don't know, a 4-year-old that fell out of a tree, then I'm going to take advantage of that person's small body size and turn up the frequency and get a much more resolute image here. And so, yeah, so frequency and body habitus kind of, you'll be adjusting that depending on the patient's size. Now, the different transducers do have different footprints. I just want to point out some basic components of that. So a large footprint, what we call curvilinear probe, or sometimes called a convex array. You hear it called a curved probe or abdominal probe. This one's got all these elements lined up in a sequential array, and the ultrasound beams fire into the body and then reflect back. But as you can see, right down the center of this probe, these beam lines are a little closer together. So on the edges of this convex array, I'm going to lose a little bit of lateral resolution, or the ability to tell that one dot are actually two dots side by side from one another. Whereas down the center, dead down the center, I'm going to get the best possible lateral resolution out of this probe. You lose a little, it's not too bad. Because of all these elements here, though, you get beautiful images from this convex array transducer. Now, look at the difference, though, when you use this phased array smaller footprint transducer here. It's really good at getting between the ribs, and for that reason, you hear it called the cardiac probe sometimes. But the phased array small footprint transducer, it's got a single crystal here, and the sound is electronically steered into the body in a very wide array. It's amazing. You can see all the way from the diaphragm superiorly in that coronal plane, all the way down to the lower pole of the kidney inferiorly on the same window sometimes because of this wide array. But like the convex array, you get the best punch lateral resolution right down the center, whereas on the edges it really splays out much more so than it did even with that convex array. I'm going to go back to that convex array and show you how there's a little splaying here. Look how much more splaying we have here. So just keep that in mind. If you need to really hone in on something, get it right down the center of the screen. That would be your best bet here. And then finally, there's the linear array, which is the same resolution across the screen from side to side. You don't have any splaying out of the sound, which really gives you the same lateral resolution when you're going side to side, and you don't lose any resolution there, which makes it a very effective transducer for looking in the superficial soft tissue. Beautiful resolution all the way side to side. The downside, though, is you don't get this splaying out, so you don't get to see out past the edges of the transducer. So whatever skin this comes in contact with, we call this an end fire transducer. The sound is coming out right off the end of it. There's no array. Now, some machines do have a way to steer this beam and do some funky stuff, which we're not going to get into in this talk, but just sort of keep in mind that when you work with the linear probe, what you see is what you get right underneath it. Because it's high frequency and because most vascular structures are very superficial, this probe sometimes gets dubbed the vascular probe. I like to call it the linear transducer because it can do so much more than just the vascular stuff. So one thing you got to keep in mind about these probes, though, is you would think in this day and time with cell phones that have accelerometers and gyroscopes and this and that, that the machine would know where the probe is. The machine does not know where the probe is. You are the one in control of where the probe is in the environment. You need to be very careful of that and keep in mind that you are the gyroscope. You need to look for this indicator here. The indicator is the way on the probe. It's trying to talk to you. It's trying to say, hey, pay attention to me. This little line here on the probe, sometimes it's a notch, a groove. It's got all kinds of different ways to identify itself. But basically, it's trying to tell you, the person handling the transducer, pay attention to me. And there's a convention in which you're going to orient me with regards to the body's axis. So what I mean is this indicator right here corresponds to the dot or the logo on the screen. And this is the orientation that we're going to be talking about here next. So in the sagittal plane, the indicator goes towards the patient's head. Okay? That's the standard convention in North America, so that everything over here is towards the patient's head. This is the inferior vena cava here, and now the inferior vena cava is down towards the patient's foot. We see it in a longitudinal plane. Sagittal means longitudinal when approaching from the anterior surface of the body. So everything over here is anterior, and the sound is being thrown posteriorly into this body. This being superior, this being inferior, again, anterior, posterior in a sagittal plane. Now, if we go to the transverse plane, the convention is to aim the indicator to the patient's right. So everything over here is to the right, everything over here is to the left. Here's that IVC again. This time it's in a short axis on the screen. It's as if you're standing below the patient's feet looking up towards the head. And finally, coronal view. This is where people get a little bit confused. Coronal, sure, the indicator is still pointing towards the patient's head, but now look at the skin line here is lateral, and the sound is being thrown medially into the body. Here's the diaphragm here again. This is all Morrison's pouch, and here the interface between the liver and the kidney. This is the coronal view. This is that classic Morrison's pouch view. Everything over here is towards the patient's head. Everything here is towards the patient's feet. So this is the inferior pole of the kidney, and this is the superior pole of the kidney. Makes sense, right? Because it's more superior, more towards the patient's head than this inferior pole was. Okay. Now, moving on, we're going to talk about depth. If there was a button that I could wear out on the ultrasound machine, it would be this one right here. So the depth here, sometimes it's a button that you push, sometimes it's a knob that you toggle. In this case here, it's a rotary knob that we're going to rotate. As we rotate it counterclockwise, the depth goes shallower, and as we rotate it clockwise, we dive deeper into the body. And let me show you why the depth is so important. Here's our old friend Morrison's pouch, diaphragm, hepatic vein. Right now we're diving 22 centimeters into the body, aren't we? We're wasting all of this screen real estate over here because all we care about is this little Morrison's pouch here, maybe from about here on down, maybe 12 or so centimeters, because each one of these dots is 1 centimeter hash mark. Every fifth dot or so I get a bigger, or every fifth dot I get a bigger white mark, bigger white mark, bigger white mark. So I can quickly tell 5, 10, 11, 12 centimeters. That's about where I need to be. So what do I need to do? In the submarine analogy, I need to go shallower. So I'm going to rotate this counterclockwise, and as I do so, it bumps up. Well, now I'm at 18. And Morrison's pouch just got bigger on the screen. If I rotate some more counterclockwise, boom, now I'm at 14. So some people would call this zoom, but zoom is not the right word. Zoom is where you zoom in on a particular part of the screen, and that's got a different function to it. Something you can play with later on. I want you to really focus on the depth, though, because when you adjust the depth, it's not just zooming in or magnifying a part of the screen. It's rewriting that image every single time to give you the best possible resolution. So that's why it's always much more important to adjust the depth before you start messing around with the zoom. I know that might sound confusing, but just remember, depth is the most common button on the machine that you're going to operate. So here we are at 14 centimeters, and now Morrison's pouch takes up the whole screen. This is a much better use of our screen real estate. Gain, or the strength of the returning echoes. When you throw sound into the body, it comes back. You can turn up the sensitivity of the machine to make it a little brighter, to make those return echoes a little bit brighter. And you can do that in two ways, really actually three ways. One way is just the rotary gain knob. A lot like the depth, this is a rotary knob on this particular device. Sometimes it's a button that you push, but right in the center of this rotary knob is something called AO, auto optimization. So I use that quite a bit. So I might give the gain a good crank, and then maybe I don't like that. I'll hit that auto optimization button. Sometimes that takes it a little bit too darker for me, and I bump up the gain a little bit with that overall. And that's usually how I approach it. However, if you wanted to adjust gain at different depths, you could do so at this control over here. It's called the time gain compensation, or TGC. Don't worry about that term so much, but what you got to know here is this is gain at different depths. I can adjust the gain at the top part of the screen, the middle part, or towards the bottom, or even all the way at the bottom only if I wanted to. This is sometimes called a gain curve, because you can kind of slide your hand along here and make it look a certain way. Now, let me show you how I use that gain. You want to make sure the gain is uniform from top to bottom. Right now, the top half of the field is overgain, the bottom half of the field is undergain. Well, I can mess around with this time gain compensation and kind of do the opposite. I can back off my top half, turn up my bottom half, get an image like that. Well, now it's the opposite. Top half's undergained, bottom half's overgained. I want to make it uniform. So what can I do? I can just back off my bottom half only, slide these slide pods to the left, and then the whole thing would be uniform. But in this case, it's uniformly undergained. So what am I going to do? I'm going to crank this rotary knob clockwise. As you can see, as you go clockwise, the gain gets a little thicker. In this case, it gets a little brighter. And boom, look what happened here. Now it's like I got to wear sunglasses. It's too bright of an image. So I might take this overall and back it down a little bit until it's perfect. I know it's perfect now because it's uniform all the way top to bottom, and it's not too bright, it's not too dark. One way to get to this level is to push that auto optimization button. But what I want to show you guys here is, if you can see that the cortex of the kidney here is slightly less echogenic than the liver, then you know you've got the gain set just right. So if I had to rank everything out in terms of their echogenicity, I would say diaphragm is number one. That's a common test question, by the way. Diaphragm is number one echogenic thing on the screen. The second most echogenic thing on the screen, I think, might be this kidney renal pelvis right here. The third most echogenic thing I'm going to say is the liver parenchyma. The fourth most is the renal cortex. See how that renal cortex is slightly less echogenic than that liver parenchyma? Good. And then the fifth, the last echogenic thing, pretty much anechoic here, is this hepatic vein. That's just anechoic blood running out of the liver and down towards the IVC. Okay, that was gain. Now, artifacts. Artifacts in ultrasound help you. When sound encounters something really dense, it gets attenuated. Attenuation means the progressive weakening of the sound as it travels into and then out of the body. So when the sound encounters something really dense, it's going to bounce right back, and you're going to get a high attenuation of that structure. This gallstone is highly attenuating, and there's a posterior shadow that happens after it. So that reflection artifact, when the sound comes in and reflects straight back off that gallstone, and a shadow is what gets produced, that helps me define that structure indeed as a gallstone, and not something more concerning like, I don't know, cholangiocarcinoma, so which won't exude a shadow like that. So as I mentioned, artifacts very helpful with ultrasound. And you can have the opposite of a high attenuating artifact, which is a low attenuating artifact. What does sound love to travel through? Sound loves to travel through water. And so we use water-filled structures to see structures that are more posterior to them. We use that as our advantage. In this case, we're looking at the urinary bladder seen here. And before I play this clip, what I want you to realize is that look how much more echo bright the structure is here behind the bladder. We call this posterior acoustic enhancement. It's the fact that the sound is traveling through the bladder, and everything behind it becomes posteriorly acoustically enhanced. And so that's what I use in order to look behind the bladder for example, free fluid in the setting of a ruptured ectopic pregnancy or a trauma fast exam. But look how, when there's a little bit of sediment in the bladder, this patient happens to have a urinary tract infection, they've got some sediment in their bladder, and you can see that sediment as the bladder jet fires. And as that left ureter fires, we can see it squirt the sediment across the bladder from left to right here. And it's just another example of how the bladder, the fluid there is so low attenuating, and it outlines other structures very well, in this case, sediment in the urinary bladder. Now, gas is the true enemy of ultrasound. When sound encounters air, it gets scattered all over the abdomen, and you can't make any sense out of it, and that's usually bowel gas. The way to overcome bowel gas, it's very simple. The patients don't like it, but you got to push. So in this case, this is somewhere in the belly. I'm not sure where we are here. If I wanted to see a deeper structure, such as psoas muscle or aorta or something like that, I would have the patient bend their legs, and then I would use 2 hands on the probe, push down with 30 pounds of pressure or so, a good amount of pressure, and then you'd see those loops of bowel either move out of the way or compress, and then you'd be able to see the structures behind it. So gas causes scatter. Refraction is a type of artifact where sound gets redirected from as it's going from one medium to another medium, it gets redirected, and there's an edge artifact that occurs. Sometimes we call this lateral cystic shattering. As you can see here on this cystic structure, the lateral edges of it are exuding these shadows, and that's straight up refraction artifact. Sound's going from one medium to another, it gets bent, kind of like Snell's law. Like the way light gets bent as it goes from water to air, and you get it looks like the pencil is bent that's sitting in a glass of water. Sound does the same thing. There's some refraction here, and you get this edge artifact. Helps me identify the edges of an organ. Reverberation artifact are equidistant arcs that come down usually from the top of the transducer. You can see these equidistant arcs here coming down from the top of this convex transducer. These are just reverberation artifacts here. It doesn't have any clinical significance, but you wouldn't want to mistake it for something. So this is some reverb coming down the top of this gallbladder here. No, that's not sludge in the gallbladder. Sludge would layer out posteriorly, and it wouldn't traverse the wall of the gallbladder going towards the organ next to it. So these equidistant reverberation artifacts, you can see them easily there at the top of that gallbladder. Now, mirror image artifact, we're going to come back to this and a lot with the fast exam and also with the pulmonary ultrasound. But basically, without getting too detailed, the machine sends some sound out of the transducer, and it's waiting for the sound to come back to the probe. And depending how long it takes the sound to come back, it plots, the organs on the screen. So what's happening, the weird thing with the diaphragm in the setting of somebody who has a normal chest, who doesn't have any fluid up here in their chest. Again, this is Morrison's pouch here. You can see the area here between the liver and the kidney. This is the diaphragm here. When the sound goes through the liver, it encounters the diaphragm in somebody who has no fluid in their chest, and it kind of rolls along the diaphragm and goes over here, and then it makes its way back to the probe. And the machine goes, huh, that was weird. I sent that sound out there. It took a little longer to come back to me than I figured it would have. And what I'm going to do is I'm going to plot the stuff that the sound was rolling through, aka liver, on further down the screen. And so it mistakenly plots liver in the chest as a reflection across this diaphragm. That's kind of how I think of it. Maybe I broke some rules there with my description, but that's, to me, the sort of how it was explained one time. That makes the most sense to me. So we can see the liver or the spleen up in the chest in patients who have a dry chest. And it looks like this. So here's your diaphragm here. Sound went down, encountered the diaphragm, rolled along it, went back to the machine, and the machine stuck the liver up in the chest mistakenly. And that's a nice artifact, because when we see liver in the chest or spleen in the chest as a mirror image artifact, then we know that that is a dry chest. There is no pleural effusion or hemothorax with very, very, very high accuracy. So we're going to shift gears a little bit and talk about Doppler for a few slides, and then this talk is over. So just bear with me here. We use Doppler a lot to look at the flow of red blood cells going through the vasculature, going through tubes in the body. And the only thing you really need to know about these tubes is that the flow through that tube or vessel is proportional to the pressure difference across the tube, and that's called Poiseuille's equation. And I probably said that wrong, but and so it's the pressure is really related to the radius of the tube, and so as the radius goes up, it goes up a little bit. You can get a lot more pressure and flow through that tube. And so what I mean by that is even with a little bit of stenosis, you're going to get really high velocities. And so that's what happens when the blood vessels get stenotic and blocked, they get narrowed, then you get these really high pressure differentials across the area of stenosis, and the flow goes up really, really, really high. And so that's what you got to think about when it comes to stenosis. You don't have to really know this equation, but you got to have an idea that even a little bit of change in radius is going to cause a big change in flow. So what is a Doppler equation? The Doppler equation, all my fellows have this tattooed on their lower back, and so if you ever need to know it, just stop any one of my fellows and you'll see it tattooed. It's part of the fellowship criteria. But the thing you got to know is the Doppler equation is trying to assess the Doppler shift in frequencies of the moving red blood cells as they go towards and away from the transducer. And of this whole equation, really the only important thing here is cosine of theta. Okay, that's really the only thing you got to know about this Doppler equation, because what does that mean? So does anybody know what cosine of 90 degrees is? Good, it's 0. Yeah, it's right here on my slide. So that's why Doppler works much better here as a more parallel plane, because this theta, once you get all the way up to 90 degrees, and if the probe is right here, the angle of inclination, once that gets to 90 degrees, then the Doppler doesn't, it's not accurate. So you really want to be more parallel when it comes to Doppler than perpendicular. But it's important to remember the difference between B mode and Doppler and angles and beam angles. When it comes to B mode, perpendicular is going to offer the best reflection and the best images possible, okay? So when you really want to look at something, forgetting about Doppler for a second, when you really want to look at something on B mode or brightness mode, TD mode, then you want to be perpendicular to that organ that you're trying to insonate. But when it comes to Doppler, it's different. You need to be off axis and think more about being parallel. For example, every time I'm driving down the freeway, for example, when my wife is driving down the freeway, this happened recently, she's driving along, all of a sudden she sees a cop right off to her right, and she jams on the brakes. And I'm like, Danielle, obviously the cop can't see when you're perpendicular. Cosine of theta is the numerator of the Doppler equation, and you're at 90 degrees right now, so clearly it doesn't do you any good to slam the brakes on. And she looks at me like I'm crazy. But the bottom line is that cop got her all the way down the freeway because they do this in a much more parallel fashion. That's when Doppler is the most accurate. And as the flow is coming towards and then away from the transducer, in this example here of pulsed wave Doppler images, you can see as it's coming towards the probe, the beam angle is constantly changing. And where it's more parallel, you get a much better representation of the actual velocity of the flow. And when it gets more perpendicular, it almost seems like the velocity is dropping. It's not, it's just not as accurate, okay? And then as the flow goes away from the transducer, again, in a more parallel fashion, you get a nice peak here. But in this case, it's underneath the baseline because it's going away from the probe. And in example A, it's coming towards the probe, so it's above the baseline. So sometimes you'll see these pulse wave Doppler waveforms going up, and sometimes you'll see them going down. You'll wonder what's going on. All it means is it's just the orientation of the direction towards the probe or away from the probe. Color flow Doppler is, as I mentioned earlier, it's a nice way to check the valvular competency. Here is a nice normal looking heart. We can see the left atrium, the left ventricle, and this apical 4-chamber view. But notice I talk a lot about Doppler. You'll hear this when I get to my cardiac stuff too, in that apical 4-chamber view rather than other windows, because in this apical 4-chamber view, or in this case it's the 5th chamber as we see the aortic valve here, during systole we see this nice blue jet bombing down the aortic valve. blue jet away from the probe. I like that aortic fifth or fourth chamber because the sound is very parallel in this view. And you can actually change the angle of the probe and make vessels turn red or blue. Here we are, one angle. We're just angling the probe here. Now the probe, the flow looks blue here. We didn't change any parameters here or change this flow box at all. We just angled the probe one way or the other. Here, though, we are changing the angle of the color angle. You can actually adjust the color angle pretty easily on most ultrasound machines by just flipping a control and see how it's this way, and then we're going to flip it. Oop, now it's this way, and just steering the color beam, if you will, can change the angle of your Doppler angle that way to a more parallel one. The pulse repetition frequency is probably the most important thing you got to know about Doppler. The pulse repetition frequency is how it's listening. Okay, so when it's sending a lot of pulses, a high pulse repetition frequency, it's talking a lot and not listening as much. And when it's not talking very much, when the pulse repetition frequency is really low, then it's listening more. And we all know that when you listen more, you're a more sensitive person. So that's kind of how I remember that. High PRF, blah, 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 not listening, not very sensitive. So when would I use that? High flow state, like the carotid, right next to where you talk in your trachea. I'm going to have a high PRF because there's so much flow going on there that I don't have to have a very sensitive sampling area. But when I'm, say, down in the testicles, where there's a very low flow state, or lymph nodes, then my PRF is really much lower because I really wanted to listen more and be more sensitive. And so you can see here on this view, we've got the PRF here at 2003. Now it's at 3,000. It's 4,000, 5,000, 7,000, and as you get up to 9,000, you don't see as much flow anymore. And then back down to 2,000, we see a lot of flow here. So that's one way that you can adjust the sensitivity is with the PRF. I usually start there. The problem with Doppler, though, is that when you activate the Doppler, you've got two things going on now. You've got the B mode, and then on top of it, you've got the Doppler sampling. And so what that does is it crushes your temporal resolution. Temporal resolution is frame rate, the number of frames per second that's passing in front of your eye. Now, on ultrasound, anything greater than 40 frames per second, you can't tell it's just a bunch of still images strung together. And so B mode ultrasound has got really high frame rates when you're using cardiac software. When you activate the cardiology package on any ultrasound machine, the cardiac software, those cardiologists, they want to see every possible range of motion that those sarcomeres are doing so that they can best assess for ejection fraction, right? And so they love high frame rate. But those images tend to be a little grainier because you're turning off all the other image processing stuff on the screen in order to get the highest possible frame rate. Because when you work with abdominal software settings, you do have lower frame rates, sometimes as low as 15, without even activating the Doppler. You're all the way down to 15 on an abdominal software setting, but the image looks beautiful because it's scraping off all the artifacts and processing that image, and so things look really pretty on the screen, not grainy. So what happens when you activate the Doppler? Well, when you activate the Doppler, and what happens is that really slows down your temporal resolution. So the image looks a little bit herky-jerky. What I mean is when you move the probe, the image kind of lags behind it. It doesn't have that high frame rate real-time image as much. And so sound is going into the body, it reflects back out, and then on the screen, it's writing those images at a certain frame rate. Adding Doppler slows down that frame rate, and then that's called poor temporal resolution. It's the number of frames per second. And you can see here how increasing the Doppler sampling area is going to decrease your grayscale frame rate. So right here, your frame rate is now high. It's 48, but we have a tiny little sampling area right here. And when we increase that sampling area, maybe we want to make it stretch out across this vessel here. Look what it's going to do to our frame rate once it refreshes. 21. It halved it just by increasing this. And so it doesn't really matter too much if you hold the probe really still. You can have low frame rates, which is fine. Now it's down to 13 here. as long as I hold my probe really still. But here's what you don't want to do. You don't want to flip on the Doppler or the color and then start dragging the probe around the body looking for a blood vessel, because the probe is going to lag behind what the image shows you, and you're going to get all kinds of flash artifact on the screen. Another way to adjust the Doppler signal is to turn up the color gain, and you could crank the color gain all the way up or crank it all the way down. That's another good place to go. So I usually turn down my PRF until I see a good signal, and then I might tweak it a little bit more with my color gain. Now, pulse wave Doppler, as I mentioned before, sometimes we call that spectral Doppler. It's a velocity waveform, and you can see this velocity scale over here, centimeters per second. This is the systolic forward flow here, and then all the way at the end of diastole, we still have forward flow going on in this particular vessel. That's what that means. It's above the baseline there. Not to get too into it, we do use Doppler, pulse wave Doppler quite a bit in our cardiac measurements, and we'll talk a lot more about that when we get to the more advanced cardiac stuff with the hemodynamics. I use it every shift in that way, but just the basics of it here. You're going to steer this sampling gate, this little TIE fighter, and that's going to result in, once you activate that in a Doppler waveform that corresponds to a velocity scale over here. And you can do all kinds of measurements along that waveform. Now that's pulse wave Doppler. Pulse wave Doppler right here, that's what we did. This is pulse wave Doppler. We did a very specific sampling location. Now the problem with that is if you've got an area that's really stenotic, and maybe a small portion of the red blood cells are going really crazy high velocities, if you don't have your pulse wave Doppler sampling gate in the exact right spot, you might miss the highest velocities going along. Like, you're only going to get what you're sampling in a very specific area. However, there's another type of Doppler called continuous wave, or CW, and this is it's a way to signal all of the red blood cells in this entire pathway, this spike that comes down. It's going to get the highest, it's going to get all of the blood vessels velocity scales in a much larger area. And so we do that continuous wave Doppler. You can see it's getting all these red blood cells here rather than just a small sampling gate here. It's actually taking this entire spectrum here, and it's getting a much larger swath of the blood vessel there. And so if you're looking for somebody who's got a really high peak velocity, you'll have a better chance of finding what those peak velocities are here when using continuous wave. And that comes in to play when you're talking about mitral valve stenosis specifically. So this is a better type of Doppler to use, because you're more likely to get the highest possible velocity values when using continuous wave Doppler. So it gives you a better accuracy. I mean, look at how high these scales are here, 300 centimeters per second. It's very, very, very high velocity due to this stenotic mitral valve. All right, so we're wrapping up here. You got to know your anatomy because you want to visualize it in two planes, define the boundaries of your organs as you're scanning through the various organs. You want to use the right transducer. You don't want to be, trying to look at the jugular vein using the phased array transducer on the neck. I mean, all you're going to see is a tiny, tiny, tiny little circle at the top of the screen. Whereas if you went to the correct transducer, the linear high frequency probe, the jugular vein is like a massive target on the screen you can't miss. And so that's one of many reasons why it's important to use the right transducer. And you're going to learn which probes to use and how to acquire those acoustic windows, where to put the probe on the skin as you peel back more and more layers of your ultrasound training. And the system controls the depth, the gain, the frequency, very important controls there to learn how to adjust. And I just kind of want to end this talk with this particular type of an ultrasound machine and how to adjust some basic controls of it. This is called a GE Logic V2, and it came out in the year 2016. And this is the control panel here. When you first see the control panel, you see all these buttons, and I think for some people, novices, they're a little intimidated by all the buttons on the screen. So I'm going to break it down and show you what the most important buttons are. In fact, we've already talked about most of them, right? We talked about the depth right here. We talked about the gain and the time gain compensation, gain at different depths. And we talked about the different modes. So B mode, color flow, pulse wave Doppler, and M mode. Now, a couple of the other controls here, I think probably the most important control is actually the power button. I mean, when you come over here, you gotta turn the power on. Okay, so that's number one. And then another really important control is the patient button here. You need to enter that patient data. We'll have this this card laminated on all the machines in case you forget, but it's here in this podcast if you want to go back to it. To enter the patient data, though, it's this button here. You click that patient key, and then you're going to enter the patient's ID. And that's really what we need on there. We need the patient ID on every single ultrasound that's ever done. So that way we know, we can see what images we're coming from, because you're gonna be archiving these images as you go along, and that's the standard of care when taking care of patients with ultrasound, is to archive the images and create a report. But specifically, you hit the patient key and you enter in the ID, and then you're going to exit that screen by clicking the scan button. Now, to select a transducer to use, a probe to use, you're going to push the preset key. When you hit that preset key, you're going to use the trackball to point the arrow to the correct probe and application for the exam that you're doing. So if you're going to do a cardiac exam on a patient, you would just go towards that cardiac exam and select it. Pretty basic. And you can always hit cancel if you're not going to change the exam type. And then to measure something, pretty easy to do. You hit the measure key, a caliper pops up, and then you're going to put the caliper where you need it, hit the set key, another caliper pops up, and you move that caliper to where the other on the other side of the thing you're trying to measure, and you hit the set key, and the result comes up. And when you're working with pulse wave Doppler, you're going to use the measure key to get those velocity values on those Doppler waveforms, as we saw earlier. To annotate an image, that means to put text on an image. Really important to annotate, especially when you're working with certain applications that are really esoteric, like some musculoskeletal applications where no one's really sure what you're looking at. I think it's super critical in general to annotate, but specifically when it comes to an organ that may not be obvious to everybody. So you're gonna hit that comment key, and when you hit the comment key, I see it over here, number 25. Then that activates the annotation function. You're going to move the cursor where you need it and put the text in, and then hit set. And then finally, to end exam, you click the end exam button. That way, all those images and the values and any comments you made get packed together under the patient ID. Really, really important to do that. It's as important as making the right diagnosis is being able to correctly archive the images under the correct patient identification number. So that basically concludes this presentation. I love this picture here of the Ultrasound Revolution drawn by one of our former medical students, Brian Lemieux. And thank you very much.